Welcome to Companion Animal Health's webinar today, Class 4 Laser Therapy. Dr. Maria Suarez from the Complutense University of Madrid is our speaker of today. If you have any questions during the presentation, you can type them directly in the chat box on the right side of your screen, or you can always email us at info@companiontherapy.com. Dr. Suarez will introduce herself, and then we will go ahead and get started. Welcome, Dr. Suarez.
Hello, everyone. My name is Maria Suarez, and I thank you for the time and the interest you are taking in watching these webinars about Class 4 laser therapy. This is a series of 2 seminars, and in the first part, we will discuss laser therapy effects, the uses, and some of the treatment parameters. I'm now a full-time small animal soft tissue surgeon at the Veterinary Teaching Hospital of the Complutense University in Madrid, Spain. I got my PhD here, and I also collaborate with the rehabilitation service. The images or slides marked as university cases need permission to be used, and a couple of the images that are shown are part of the book of which I am a co-author, Veterinary Laser Therapy in Small Animal Practice, and in that case, it's indicated as well. I had the pleasure of writing it with Brian Stevens, who's an extremely intelligent and talented physics PhD and a great communicator of the hard science behind lasers. The contents we'll go through in these 2 webinars include a brief review of laser therapy and other similar terms. How does it work at a cellular and physiological level, and what's the science behind it? These effects will be translated into clinical applications. We will mention the most common ones. And throughout this webinar and the next one, I'll present the main parameters of laser therapy, such as dose, power density, and others. In the first webinar, in particular, we will review dose and power. Power density is covered in the second part. We'll see some clinical examples with cases in this lecture, but the next one will present more clinical cases with specific tips and parameters for wounds, orthopedic conditions, and others. And eventually, we'll review laser contraindications and safety considerations. I hope I can help you solve at least some of the most common questions regarding laser therapy, including doubts about scientific background, differences with LED devices, whether it's possible to hurt patients, and about some very common topics in practice, like the combination of laser therapy and metallic osteosynthesis implants, and about the use of laser in infected tissues. You know that laser therapy is a form of photobiomodulation, which is using light to influence biological processes. And you may have heard other similar terms, such as low-level laser therapy. This refers to using light for therapeutic purposes at an intensity that is low compared with surgical or ablative lasers. The term cold laser is not my favorite. It's often used with low-power devices. The North American Association of Laser Therapy officially adopted the term photobiomodulation about 16 years ago, but photobiomodulation also includes LEDs. Laser light, as you know, is monochromatic, is collimated and coherent, and LEDs are also monochromatic but not coherent. So for skin conditions, they are interesting, but the penetration ability is very different in LEDs and lasers. And more recently, with the increase in availability of high power lasers, of Class 4 lasers, some prefer to use the term high-intensity laser therapy to differentiate it from laser therapy that is performed with lower power devices. So how does light interact with tissues? How does it work? When light reaches a surface or a tissue, we can observe 4 types of phenomena. Light can get reflected, it can get absorbed, it can get transmitted or scattered, which is transmission, but with a different angle. If tissues were completely reflecting the light or completely transmitting it, there will be no effect. To have an effect, molecules or parts of molecules must be able to absorb the light. And these molecules that are able to absorb the energy the light carries are called chromophores. There are four main ones in the tissues for the near-infrared light. We have melanin, water, cytochrome C oxidase, which is part of the respiratory chain in the mitochondria, and hemoglobin. When these molecules absorb the energy, the result is better blood supply to the area, more oxygenation, and increased tissue metabolism. Other molecules and cellular mechanisms are involved, such as nitric oxide and ionic channels. And chromophores have a range of wavelengths they can absorb, but to reach them, we first must bypass melanin, which will absorb and block a very big part of the energy on the surface of the patient. This is a logarithmic scale representing the absorption spectra of some of the chromophores. The tissue optical window is the range of wavelengths that can penetrate into living tissue and stimulate those chromophores. And it ranges from about 6 to 1100 nanometers. If you notice the figure, the closer we are to 600 nanometers, the more absorption we get by melanin. And if the melanin absorbs the energy, it has at least two consequences, two implications. One is that that energy is not going to reach to deeper targets. And the second is that the skin can become warm, especially dark-coated patients. To avoid that, some devices have some helpful features, like the option to select what color and length of coat does the patient have. And second, a mechanism in the handpiece that will detect if we are moving it too slowly and then change the color of the light from green to red. As you can see in the video, the energy is delivered over a certain area in scanning mode. The joules of energy per treated area, or joules per square centimeter, or energy density is what is called dose in laser therapy, and we'll get back to it shortly. The physiological effects that translate into clinical effects can be divided into three main categories. Laser therapy can improve the rate and the quality of tissue repair, such as in wound healing, but also in other tissues like muscles and bone. It has an anti-inflammatory effect and anti-edema effect, and it's also analgesic. A common phenomenon under these three effects, and probably one of the first things we see in the tissues, is the change in blood flow. When we treat a wound, for instance, the color of the tissue is not the same before and after the laser therapy. So the change in blood flow is pretty fast, and it's mediated both by temperature microgradients and a release of nitric oxide and prostacyclin. But the increase in blood flow is not only in the short terms, it goes beyond a quick vasodilation. Laser therapy also increases the production of growth factors that have a pro-angiogenic effect, like the vascular endothelial growth factor. So under the microscope, the tissues that have been treated with laser therapy in the midterm are more rich in neovascularization. And the vasodilation that happens is both in the inflow and the outflow. So we have an anti-edema effect. It's not just more blood going into the tissue. The vascular effects have been studied in several species, including horses. This study from 2020 used thermographic imaging to track the changes in surface temperature after treating that area. And they also use ultrasound to measure the diameter of the lateral palmar digital vein before and after laser therapy. Both parameters were significantly increased after what they call high-intensity laser therapy, which is class 4 laser therapy treatment. And the same research group later on published a very similar study, but this time separating pigmented and non-pigmented horses. And they describe an increase in skin surface temperature in horses with pigmented skin and a decrease in horses with non-pigmented skin. But the vein diameter increased in both groups. We will not discuss wound healing in detail, that is beyond the scope of this seminar. But in summary, you know that wound healing consists on a preliminary inflammatory phase that turns into a proliferation phase that includes 4 phenomena, which are angiogenesis, granulation, wound contraction, and eventually epithelialization. And then after the wound is closed, the tissue undergoes remodeling for months or even for years. Well, laser therapy can help in each of these phases, except the initial hemostasia, because it improves the efficacy of the white blood cells fighting potential infection, while it promotes what is probably the most important change we need to see in a wound, the change from the inflammatory phase into the proliferation phase. So from catabolic state to anabolic state. Once in the proliferation phase, with laser therapy, we are going to increase the number of fibroblasts, their ability to migrate, and their collagen production, especially type 1 collagen, which is more interesting for achieving more tensile strength eventually. We are going to have also a higher number of new blood vessels. Fibroblasts are going to differentiate more into myofibroblasts, which are going to help contract a wound. And we are also going to have more keratinocytes, which are going to migrate faster. In other words, the wound is going to granulate, to contract, and get epithelialized faster. So the tissue is not going to experiment abnormal changes, but it's going to have a metabolic engine that is working faster and that has more fuel to do it in the form of more blood flow and more oxygen. So the result of treating wounds is that with laser therapy is that they heal faster, with less inflammation, less risk of complications, and with a resulting tissue that has a more tensile strength, between 20 and 60% more, depending on the paper. This kitten underwent surgery for a diaphragmatic hernia, and everything went well, except that he got one of his foot trapped with the ICU cage, and suffered an injury that included a fracture with avulsion of the 5th digit. You can see the metatarsal head coming out of the wound there. And the 4th digit was initially very ischemic, and we thought the distal phalanx and pads would be lost. But we wanted to avoid another surgery, so we started laser therapy. By day 5, it was very clear that surgery would not be needed. We performed a total of 5 treatments during the first 2 weeks. And in our recheck visit, a month after we started treating, we saw that not only the skin wounds had healed, but in the 4th digit, with what was left of the tissue, a new foot pad and nail had grown again. There are hundreds of papers documenting the effect in wound healing, most of them in experimental animals, but also clinical studies in dogs and humans. In experimental animals and human patients, we do not only have single studies, but also meta-analysis and reviews, which are a much stronger form of scientific evidence. For instance, this review from 2010 concluded, after reviewing 47 studies with mice and rat, that there was a consistent benefit in wound healing. But look at these sentences, which we unfortunately find in almost every similar review or meta-analysis with laser therapy. They literally say, considerable variation was observed in research design, methodology, and irradiation parameters employed, limiting comparison of research findings between studies. Inadequate reporting of key experimental details or errors in specification and or calculation of key radiation parameters was also found. And these are very frequent problems when we try to compare studies. The irradiation or treatment parameters are very variable from one study to the other, and sometimes it's information that is not even disclosed. Clinical studies in people with wounds also show positive results with the right parameters, including in 2 challenging situations in human medicine, which are diabetic ulcers and pressure ulcers, probably the 2 most common chronic wounds treated in people. More recently, this paper came out evaluating the clinical score for incisions after hemilaminectomy in dogs with or without photobiomodulation, and found that daily laser treatment for a week improved the scar score and cosmetic healing. This is from that paper, and in the figure on the left, you can see how wound scores were different from almost the beginning of the treatment and were still different by the 3rd week. And on the right, you can appreciate the difference by the 3rd week between patients in the control group, which are the top 2 pictures, and a patient of the laser therapy group, which is the bottom picture. In this case, the patient had been hit by a car some weeks ago, and as a consequence, he developed radial neuropathy and wounds from dragging and chewing on the limb. And because these wounds were not protected, they got worse and worse. There was a lot of inflammation and edema in the distal limb. These pictures are from the first day we met and started treating this dog. With the combination of laser therapy and, of course, appropriate wound care and protection, we cannot do laser therapy and leave the wound as it was. Well, the wound started to improve, and on day 2 of the treatment, the tissue had a better aspect and much less edema. 1 week after the beginning of the treatment, the wounds were significantly better. We already had epithelium growing on top of the granulation tissue. And of course, we kept it bandaged, taking extra caution to avoid excess moisture buildup between the digits and the pads. And on day 16, after 6 treatments, this was the limb compared to the beginning from one side and the other. Laser therapy promotes healing in other tissues, not just the skin, like the muscle. It increases the biochemical activity of the muscle, the number of myofibers, and it also helps muscle repair by having an anti-inflammatory and pro-angiogenic effect. It also improves performance and post-exercise recovery, according to some studies. And because it has a big impact on collagen synthesis, as we mentioned, laser therapy can be used in tendon and ligament healing, especially because not only global collagen synthesis increases, but because type 1 collagen is promoted with laser therapy, and type 1 collagen has a more aligned, a more organized disposition of the fibers in the space, and so it provides more tensile strength to the resulting tissue. So same as it happens in wounds, we get more collagen 1 we have in tendons and ligaments. In this study, published in 2010, they found the maximum percentage of type 1 collagen was created if laser therapy was combined with ultrasounds, using first the laser therapy and then the ultrasounds, and see how there's almost a 6-fold increase in the laser and ultrasound group compared with the control group when they analyzed the percentage of type 1 collagen. Using a class 4 laser, this study from last year described the effect of laser therapy in an experimental model of horse tendon healing. They created lesions in 4 suspensory branches and treated 2 of them, using the other 2 as controls. And the lesions in the treatment group were significantly smaller in size, as documented by ultrasound and MRI. And on Doppler mode, the treated lesions had increased signal. This therapeutic effect for tendon and ligament injury has not only been demonstrated in experimental models, but also in case reports and clinical studies, such as these ones, in which they describe return to sport activity in horses. The last one included 26 horses with tendon and ligament injuries, and they evaluated the effect of high-intensity laser therapy or class 4 laser therapy on them. They underwent a similar rehabilitation program, plus they were randomly assigned to a laser-treated or non-treated group. They had a total of 15 treatments, and they performed clinical and ultrasound assessments before, during, and after the treatment, and found that after the treatment, pain, swelling, and lameness were significantly improved after laser therapy compared with the control group. and there was a significant decrease in lesion on ultrasound compared with the controls. In bone tissue, laser therapy is also able to enhance osteogenesis, to increase bone graft viability when bone grafts are used, and also has a beneficial effect on the tissue around the fracture, which is very important for the bone survival and the fracture healing itself. In experimental animal models, laser therapy accelerates the repair and the functional recovery after anastomosis and after crushing injuries as well. We're talking about nerves now. And some of the mechanisms involved are the increase in some growth factors, and especially to the modulation of the inflammatory response that's associated with the nerve injury. And this determines the type of differentiation the microglia undergoes, which is very relevant to the final pathological process. And there are promising results in the field of laser therapy and traumatic brain injury, ischemic stroke, and other central nervous conditions. If you are interested in this topic, I recommend you this book. Photobiomodulation in the brain is fascinating. And while it's not, there is no substitute for surgery when this is indicated, when surgery is indicated, we can use laser therapy to help both in the post-operative recovery and as part of a conservative approach, if that is the best option for intervertebral disc disease. A couple of clinical studies in dogs undergoing hemilaminectomy alone or plus laser therapy show that laser-treated animals recover ambulation quite faster. In the study on the left, it was 3.5 days versus 14 in the non-treated animals. And in the study on the right, which is a bit more recent, it was 14 days versus 24 days with laser and non-laser animals. So not as marked, but pretty impressive in both cases. This improvement we see in patients after hemilaminectomy and with the conservative approach as well is probably due, at least in part, to the anti-inflammatory effect of the laser therapy. After wound healing, it's the most studied and reported effect of laser, the anti-inflammatory. What studies tell us very consistently is that laser therapy decreases the production of most pro-inflammatory mediators. And this has been demonstrated with the interleukin-1, with tumor necrosis factor, with the COX-2, and prostaglandins, and others. Tissues treated with laser therapy show a decrease in the amount of inflammatory cells, in exudate production, and macrophages differentiate more into the M2 phenotype, which broadly speaking is anti-inflammatory. And this decrease in inflammatory mediators is what happens in osteoarthritis, for example. This recent meta-analysis describes how inflammation biomarkers and cells, which are part of the inflammatory soup, are modulated by laser therapy. And the anti-inflammatory effect can also be seen in other tissues. These two studies describe the effect of laser therapy in gingivitis and in colitis. Both are clinical studies with canine patients. In the first case, they use laser therapy as an adjunctive therapy after dental cleaning, treating half of the mouth and using the other half as a control. And in the second case, dogs with chronic large intestine diarrhea were treated with either with prebiotic treatment or with laser therapy. And the laser-treated dogs were 4 times less likely to develop diarrhea, to experience diarrhea, compared to the control group. This is an example of the anti-inflammatory effect with wounds. This cat had surgery 2 weeks before, and she was very intolerant to the E-collar, and she had been licking the wound for several days, but the owner could not bring her in before because she had been quarantined. The cat was already on cephalexin with apparently no improvement. The wound was covered with Manuka honey and sterile dressings, and we started with laser therapy. The dressings were held together by a protective suit which was much better tolerated by the cat. And with the laser and the honey, the wound started to be less inflamed and heal. And the cat also started to pay less attention to it. The last picture is on day 13 after the beginning of treatment with a total of 5 sessions. This dog had Addison's disease plus a peripheral neuropathy. The consequence was that he had lost almost all digits in the left foot. He had some smaller wound on the left hand, and he had a very complicated wound on the right hand. But the poor guy was still walking. This is how it was the right hand. It was a complete disaster. You can see there are fractures and osteomyelitis signs in every finger, every digit. So culture was taken from the right front wound. We retrieved multi-resistant E. coli and staph. We treated for a few days with the resulting antibiotics and laser therapy, not to avoid surgery, but to get to the day of surgery having the tissue in better conditions. In another dog, a full limb amputation would have been considered, but because in this patient the other limbs were not normal, we decided to try to keep a weight-bearing surface. So we performed amputation at the radiocarpal level, preserving part of the soft tissues to create a flap with a central foot pad. And laser helped a lot with postoperative edema and inflammation, and with flap healing, which was successfully achieved. We treated daily for the first 2 days and then 3 times per week when bandages were changed. Laser therapy also has an analgesic effect, and the reasons behind this that have been reported include the anti-inflammatory effect, which is mentioned, because more inflammation means more pain, and because inflammatory mediators are also involved in peripheral and central sensitization that contributes to chronic pain. Other mediators are modulated by laser therapy, such as the kinin system and substance P. An increase in endogenous opioids has been described too, as well as an increase in serotonin. And some papers also describe a change in depolarization of the afferent fibers that carry the pain signal to the central nervous system. All these eventually lead to an increase in pain threshold and analgesia. And these effects and this mechanism have been described in experimental animals, but also in clinical trials in human patients too. And again, even better than single trials, we have reviews and meta-analyses that have been published for quite some time. This is not entirely new. This paper, for example, was published in The Lancet. It's a meta-analysis from 2009 describing the effect of laser therapy in people with chronic neck pain. In the meta-analysis from 2012, that's shown there, they were studying painful joints treated with laser therapy, and the mean weighted difference in change of pain on a visual analogic scale was almost 14 millimeters. This other from 2017 included 18 studies and concluded that low-level laser therapy is an effective treatment modality to reduce pain in adult patients with musculoskeletal disorders. Now, this last paper just came out in June this year, and it's another meta-analysis describing the analgesic effect of laser therapy for musculoskeletal pain in people. It includes over 1,000 patients from randomized control studies, about half of them receiving placebo treatment and half of them receiving laser therapy. And although the placebo effect was able to induce some analgesia, only laser therapy was effective in improving disability scores and functionality. The question is not anymore whether laser therapy is effective or not. The real question is, what are the optimal parameters to achieve that? Okay. All these reviews and meta-analyses point out the need to report, to control, and to standardize those treatment parameters. If you feel a bit overwhelmed with the joules, watts, and so on, there is good and bad news. Bad news is that you do need to understand those if you really want to understand what you're doing and get the most from laser therapy. And good news is that it's not that hard, and that once you are a bit fluent with that, it becomes as easy as calculating dosages for drugs. And there's more good news. You are not alone. This article from 2020 is a multi-center study carried out with veterinary practices in Missouri, treating dogs with osteoarthritis with laser therapy. And only 65% of respondents were aware of the dose they were delivering. And this for a therapy that in just a year, with just one specific use, just one joint, in one species, only in one US state, generates more than $6 million a year. So now we will overview the clinical applications of laser therapy with a couple of examples. And right after that, we'll discuss dosing. So you are in that 35% of people who know what dose they are using with their patients. Because the effects we have mentioned on tissue metabolism, blood flow, inflammation, and pain can be incorporated to, these effects are general treatment goals in many pathologies, in many conditions. So laser therapy is very versatile, and we can incorporate it to the treatment of many conditions. In general practice, probably at least 50% of patients are candidates for laser treatment. Laser therapy is indicated as part of the treatment in almost any type of wound, whether it's acute, chronic, infected, burns, or surgical incisions. The only contraindication is wounds with severe active bleeding. And in oncologic wounds, it might be better to wait for the pathology report, because although infrared radiation is non-ionizing, it's going to enhance local metabolism and angiogenesis. And these two phenomena are probably something we don't want to stimulate in an oncologic one. Laser therapy can also be incorporated to the treatment of otitis and gingivitis, sialoadenitis, perennial conditions like sacculitis and fistulae, and quite a wide variety of dermatological conditions like hotspot, non-inflammatory alopecia, and cellulitis, and others. Of course, to access structures that are deeper than the skin, we need not just the right wavelengths, but also enough power. So with the right wavelength and power, and although not as frequent, laser therapy can also be incorporated to the treatment of some abdominal and thoracic treatments, such as asthma and cystitis or colitis. For neurological conditions, probably the top two targets would be neuropathic pain, like the pain associated but not exclusive of osteoarthritis, and IVDD as an adjunct treatment after surgery, or for the conservative management when surgery is not indicated. And of course, we also use laser therapy as part of the treatment in osteoarthritis, spondylosis, injuries in tendons and ligaments, muscle trauma, muscle contractures like iliopsoas contracture, and fractures. Now, although laser therapy is versatile, there are limitations to what is the spectrum of action. And laser therapy, the applications of laser therapy do not include avoiding surgical treatment for fractures. You still need to go into the OR with the fractures. With the acute disc extrusions, it happens the same. Laser therapy is going to help with gingivitis, but it's not going to cure the calicivirus. And it's going to decrease colony-forming units on the surface of wounds, but it's not to disinfect a surface. And it's going to help with clinical signs associated with some autoimmune diseases, but it's not going to cure the autoimmune disease itself. I'm going to show you now a couple of farm animal cases, although I told you I only do small animals, but sometimes the farm animal service will consult with us for wounds. This was on the lateral aspect of the neck of a sheep as a result of a dog attack, and the wound was very deep. Cervical vertebrae were partially exposed, and there was quite some necrosis present. Unfortunately, the animal was euthanized a few days later due to an injury in the leg, so I cannot show you more pictures, but we managed it for 10 days with laser and honey, and you can see the evolution in 10 days, which was pretty good. This case was quite challenging. This 3-month-old calf developed necrosis in the distal segment of both hind limbs. It started with dietary problem, with a diet management and acidosis, and with a combination of self-debridement, autolytic debridement, and surgical debridement, both parts got removed. And this is her tissue 2 weeks after the former pictures. Not bad at all. We were treating 3 times per week, and the evolution in the next weeks was excellent. Notice how the granulation is complete, and there is already some epithelialization, and also the hair starts to grow back on most of the wound. My colleague Rosa Mendaza designed and produced prosthetics for her, and this is a video with the prosthetics, which were later modified. The animal was donated by the owner and went to live in an animal sanctuary. Now we will discuss 2 important treatment parameters, dose and power. With any treatment, dose is a parameter to control, and in laser therapy, the concept of the dose represents the joules of energy per treated area, or joules per square centimeter. It's also called fluency or energy density. And because the area in which we distribute the light is part of the definition for dose, if we don't measure or at least make a good estimation of the treatment area, we cannot be aware of the dose we are using. The range of doses that we use is wide, is from 1 to 30, although 2 to 20 is more common. And the dose we select is influenced at least by 2 factors. One is how acute versus how chronic the condition is, and second, how superficial or deep are the targeted tissues. The more acute and more superficial the condition is, then the lower dose we need. So it's true that with some therapies, the margin of therapeutic dose is quite wide, but we always need to have an idea, to be aware of more or less what dose we are using, not just because we want to stay within therapeutic margins, but also because it's one of the first parameters that we need to check, and we are going to maybe modify if the clinical response seems insufficient at the beginning. For acute superficial wounds, we need only 2 to 5 joules per square centimeter. And on the other hand, if we are treating very chronic wounds or very deep conditions, the starting dose is around 4 or 5 joules per square centimeter, and we often treat with 10 or more joules per square centimeter. For some very challenging conditions, like feline eosinophilic complex and leak granulomas, sometimes doses of 20 to 30 joules per square centimeter have been described. If we take degenerative joint disease as an example of treating chronic deep conditions, the average dose, to make things more simple, is probably around 10 joules per square centimeter, although for a carcass of a very small dog, we probably need less. And on the other hand, for the hip of a large dog, we will try to get somewhere between 10 to 15 joules per square centimeter. There is still some debate about what is the best dose and where does it become too much. A study in mice with experimental wounds and second intention healing found that 30 joules per square centimeter were more effective than 3. But other studies find that 20 joules per square centimeter is already too much for superficial wounds. This review we mentioned before that included 47 studies with mice and rat. It reported the median dose in those studies was 4.2 joules per square centimeter. A similar dose was described in this other review of laser therapy in diabetic wound healing in human patients. In this case, the author describes how studies that use a dose of 4 joules per square centimeter, 3 to 5, usually have more satisfactory results. Other studies have found beneficial effects with higher doses, like the paper we mentioned with dogs treated after hemilaminectomy. They were treated daily for a week with a dose of 8 joules per square centimeter, and they got excellent results with that. In this case, by selecting the patient species and size, the conformation or body condition, the treatment area, and the type of condition we want to treat, the laser will automatically calculate a standard dose. Also, in wounds and other programs, you just have to select an estimation of the treatment area, allowing for some margin, and the device will then deliver about 4 or 5 joules per square centimeter for a superficial wound and about double for a deeper one. That makes treatment very consistent in dose. But it's always good to be aware of what we are doing, because there may be other scenarios in which things are not that crystal clear. Imagine we select through different screens until we get to our treatment for an arthritic shoulder of a mid-sized dog. Okay, and the screen's telling us that we are going to deliver 1400 joules. Now, how do we know is that's a lot? Well, we can measure our treatment area, and for example, it turns out to be 10 centimeter wide and 15 centimeter long. That makes 150 square centimeter. So 1400 joules divided by 150 square centimeter gives a dose or energy density of about 9-10 joules per square centimeter, which makes sense for a shoulder with chronic pain. Now, if we change the treatment area with this same case, with this same program, and we extend it to, let's say, 500 square centimeter, because we decided we should also treat the scapular muscles and a bit of the caudal cervical spine. Well, if we spread that much, our initial amount of joules, the joules per square centimeter are going to decrease. So the density of the energy or the dose is going to be lower. For instance, in this case, if we increase the area to 500 square centimeter, the dose would only be about 2.8 joules per square centimeter, which is likely to be too little for this patient with a chronic shoulder pain. I am not saying that we should not treat the muscles of the spine or the muscles of the scapula, but these areas should be treated with their own dose, and they should be included in the treatment area calculations from the beginning. Now, to deliver the energy, to deliver those joules, we need power. It's the concept that represents how many joules can be delivered per unit time, and it's measured in watts. Intuitively, power is somehow similar to brightness. With 1 watt of power, we can deliver 1 joule in 1 second. If I only have 0.1 watts or 100 of milliwatts, which is the same, of average output in the device, I can only get 0.1 joule in 1 second, or in other words, it would take 10 seconds to deliver 1 joule. And with 10 watts of power, we can deliver 10 joules in 1 second. So the higher power is used, the faster a treatment can be delivered. That doesn't mean that we always want to use all power available. We'll see. The reasons to look for higher power, though, are that first, power allows us to deliver more joules in a shorter time, but also to reach deeper with a higher photon density. And let's see an example. An example of saving time, or not just saving time, but performing the treatment in a clinically reasonable time. Imagine we want to treat the thoracolumbar area of this small to mid-sized dog, and the area is 150 square centimeter, and we want to deliver 10 joules per square centimeter. That would be a very standard dose for this dog, and that means we want to deliver 1500 joules in that area in that session. Well, if the power we can use is, let's say, 12 watts, the treatment would take little more than 2 minutes. With 1 watt of average power, we would need almost half an hour to deliver that dose, scanning the area in a uniform way. And if we only had 0.2 watts or 200 milliwatts, so a class 3B laser, we would need more than 2 hours. So with lower power lasers, usually the treatment technique is only at certain points and not in a uniform scanning way. Second, we said we want power to reach deeper with a higher photon density because the percentage of power loss increases as we penetrate into the tissue. So having a higher power to start with in the surface will allow us to reach deeper with a higher photon density, which means having a more chance of having a biological effect. The international classification for laser types is based on their power and also takes into account wavelength. But any device with output power over 500 milliwatts or 0.5 watts is considered a class 4 laser. And because of that, class 4 therapy lasers, surgical lasers, or lasers to cut metal in a factory all get included under that class 4 umbrella, but obviously the implications, the dangers, and the uses are different. Here are some guidelines to combine dose and power. For superficial soft tissue conditions, an average of 1 to 5 watts is used in class 4 laser therapy, with peaks between 2 and 8 in most cases, although you could use a bit higher for a large dog abdomen, for instance. An acute wound can be treated with 2 to 5 joules per square centimeter. So the more acute the wound is, the more conservative we are with dose and power. And to treat deeper tissues, for instance, in the perineal area or the abdomen, we need more power, 3 to 6 watts, and around 10 to 20 joules per square centimeter for a chronic condition. The same high dose, but with a lower power, so a dose of 10 or more joules per square centimeter, but with a lower power, may be used for a very chronic but superficial ulcer. And well, this is just a general frame because, as we'll see, power is only one part of the information. But if higher power and doses seem to work better in some cases, that is especially true for chronic pain. In this recent review, the authors comment the studies that demonstrated positive effects of high-intensity laser therapy, so class 4 laser therapy, on pain have some common features, such as using higher amounts of energy, higher amounts of power between 3 and 25 watts, and use of laser therapy for at least 10 sessions. These would be some examples of how we can combine dose and power for the treatment of degenerative joint disease as an example of treating chronic deep conditions. In a corpus of a small-sized patient, we would use a dose of 5 to 10 joules per square centimeter, and around 4 to 5, 6 watts would be enough. For thoracolumbar spondylosis in a medium-sized dog, the average dose would be around 10 joules per square centimeter, although some patients will respond with lower figures, and we would use at least 6 watts of power if possible. And for the hip of a large dog or a very large dog, the minimum dose for chronic pain would be 10 joules per square centimeter, often 15 or even more, and we would be using all power available. So in summary, the effect of laser therapy after being absorbed by the chromophores is that the circulation and oxygenation are increased, ATP production and cell survival increases as well. There is modulation of the inflammatory response. There's analgesia. And all these lead to faster tissue healing and recovery. Laser therapy can potentially be incorporated for the treatment of many conditions that present with inflammation, with pain, and that need tissue healing as a therapeutic target. Always as long as we can reach those tissues with the right wavelength, power, and dose. And dose, which is joules per square centimeter, and power, which is measured in watts, are generally lower for acute superficial conditions and higher for deeper and more chronic ones. Remember, treatment area is part of the definition for dose, so we should always try to make a good estimation or measure the treatment size, the treatment area size. Thank you. This is the end of the first webinar.
Thank you very much, Dr. Suarez, for this excellent information and very informative webinar. For any questions that you may have, you can email us directly at info@companiontherapy.com, and we invite you all to join us for the second part of Dr. Suarez's webinar. Thank you very much. Goodbye.